Welcome. I'm glad you were able to join us. My name is Lisa Getland, and I'm the project coordinator for the Clinical and Translational Sciences Award that RTI received in partnership with UNC. And it is my pleasure on behalf of the CTSA team here, as well as the Fellows Program, to welcome and introduce our speaker today, Dr. Tim Carey. Dr. Carey is the director of the Cecil G. Sheps Center for Health Services Research at UNC and a Sarah Graham Keenan professor in the Department of Medicine and Social Medicine at UNC. He is currently a senior advisor to the RTI UNC Evidence-Based Practice Center, and associate director of UNC's program on ethnicity, cultural, and health outcomes. And he also plays a key leadership role in the CTSA at UNC, as well as directs the CTSA Comparative Effectiveness Research Initiative. So a central goal of the CTSA project is to build connections and build new research collaborations between UNC and RTI. And so it's in that context that Dr. Carey is going to talk about the Carolina Data Warehouse for Health. I'm going to turn over to him.
Thanks, Lisa. Hi, good to see some friends here, and the rest of you. But the little light's on. Okay. And I'm a health services researcher. I did my first medical records abstraction project with RTI in the late 1980s. So I've been working with y'all for some years now. And started working with electronic health records actually when I was in medical school back in the 1970s at the University of Vermont, where we had a completely electronic medical record at UVM in 1974. This is not new technology. It's been around for a while. But now we're at the point where we can actually begin to use it to actually analyze care better and use it better. And wanted to let you know about some of the innovations we've developed at UNC over the past couple of years, and talk about collaborative relationships. I'm going to pretty quickly go through the slides because I think most of the fun's going to be actually talking about things. Again, this is not new. Electronic health records and data warehouses, these are medical records. Dr. E.O. Codman, now, Wolfham's on the line, right? Who was E.O. Codman? All right. E.O. Codman was a professor of surgery at Mass General Hospital over 100 years ago. And he had the idea that he would publish his results. And lots of people lived, but a lot of people died after things like appendectomy and gallbladder surgery, routine surgery back then. And he also had the great idea that not only would he publish his own results, he would publish those of his peers in the New England Journal of Medicine. Dr. E.O. Codman was then ejected from the medical staff of Mass General Hospital and actually founded his own hospital because he came from money. There's actually a Codman Square in Boston called the Codman Hospital. Got drafted into World War I and was actually never the same again. But the spirit of E.O. Codman lives. And looking at medical records was assumed to be the best way to assess physiologic health status, the care delivered, as well as tests like lab and imaging results. And back in the day when I was working with RTI in the late 80s looking at Medicaid data, we abstracted 12,000 Medicaid charts in 3 states. And it was one record at a time. And electronic medical records, up until recently, basically were staring at screenshots, which basically was a little bit easier. You looked at the screen and you put it into an Excel spreadsheet. Still pretty crude stuff. Electronic medical records are not new. They've been around since the 60s and 70s. Up until recently, they were all homegrown and fairly university-based. UNC had one that I helped develop 25 years ago. Mass General had one. The Brigham had a different one, of course. Vandy had one, Salt Lake City, on and on. But there was really glacial dissemination up until the 2000s. and none of them were compatible with each other really until 2010. In the last decade and the last 5 years, there's developed a complex regulatory environment, which is partially based at CMS, partially based at the Office of National Coordinator for Health IT, as well as others, with a complex structure of incentives and penalties for what's called meaningful use of health IT, which is a good idea and a good thing, but which also perturbs both the care delivered and the documentation of that care. The HITECH Act of 2009 gave both carrots and sticks, incentives and penalties for providers to install certain types of systems and use them in certain ways, with this focus on meaningful use. If you talk to any physician for more than about 5 minutes, the snark will start about how meaningful is meaningful use. Key in the last 5 years has been market consolidation. When we looked at the EMR horizon in North Carolina, the environment in North Carolina in 2009, 2010, right after passing of the HITECH Act, there were at least 40 major vendors across the providers. However, in parallel, or maybe it's causal, and I'll be interested in your thoughts, with the purchase of practices into large integrated delivery systems, the market has consolidated to Epic, Cerner, GE, locally Allscripts, and a couple of others. And rapidly, we're probably going to be down to 3 major vendors in the very near future. And we can discuss whether that's a good thing or a not so good thing. Also, information is now being exchanged in health information exchange. This was mandated by the HITECH Act of 2009, has gone much more slowly than we thought. And some EMR data is very easy to move from place to place. ICD-9 codes, ICD-10 codes, LOINC codes for lab data, but a lot of EMR data is a lot less structured. It's still unfiltered text, blobs of textual files. But they have actually gotten what's called a continuity of care document, which gives a lowest common denominator for communication. Problem list, medication lists, which are coded, allergies, which are coded, and laboratory data. And this is actually sort of working, although the vendors all want you to be able to exchange data within the Epic or Cerner environment, which it turns out is much easier than going outside the Epic or Cerner environment. Why we're surprised that the vendors are behaving in this way, which is sort of typical behavior. General Mills wants you to buy other General Mills products. Epic wants you to buy other Epic products. I don't know why we're surprised. So the current environment in our state is that Epic, the Epic Corporation, is the dominant vendor with greater than 60% of people in North Carolina on an Epic chart by the end of this year. Within 2 years, it will likely be 80%. That's not 80% of providers, but 80% of people, because Epic goes for large institutionalized providers. What's going to happen with the small practices like community health centers is not clear. And there's a lot of concern and effort at UNC and elsewhere to make sure that we can exchange information with practices that take care of our most vulnerable populations. So these may wind up being hosted systems rather than hosting their own systems. As I mentioned, information exchange is easier within than between vendors. Data extraction out of the EMR, so it's not the Roach Motel of medical data where the data goes in but can't come out, is getting a lot easier. But we still need to harmonize variables across sites and get better transfer protocols. And at UNC, about 48 days ago, 12 hours, we turned off our old system at 7 a.m., turned on the new system. I was on call that weekend. I can't tell you how much fun it was. We were able to integrate patient records across the health system entities now. UNC is one of the large integrated delivery systems. We are, as of today, 8 hospitals. Tomorrow, who knows, as well as dozens, if not over 100 practices. So this provides visibility to patient enrollment in studies. Okay? I'm getting to research. And it enables improvement in research billing administration and compliance, because classically at UNC, we were terrible about allocating charges appropriately into research, and we lost a lot of money that way, since Medicare does not pay for research, nor should they. Reduces the development cycle for patient registries and research documentation, which we really need. Registries take a long time, And because they take a long time, impatient researchers would do things like make up one on their own, put it in an Excel spreadsheet on an unsecured server underneath their desk. Yeah. Also, this gets us a platform for patient-reported outcomes, and I'll come back to that, for enabling quality improvement and pragmatic trials. And that didn't, never mind. Okay. This does give us an integrated database that'll enable improved data mining capabilities and research discovery, such as what we used to have were these application silos where, although our CPOE and our physician documentation was one database, we actually had a separate database for the emergency department because they just wouldn't join in with everybody else because they're ER docs. A separate database as a patient portal that never worked very well, and now all of these are pretty much consolidated within Epic Care. There were still a few standalone legacy systems, but a lot fewer than we used to have. And Cerner does pretty much the same thing in their systems, GE a little bit less so. So at UNC, and you would probably have the same discussion from my colleagues at Duke, if Ed Hammond were over here, we have 6 or 8 hospitals, depending on how you count Hillsborough, and we're bringing them on sequentially onto Epic. Rex goes live in about 3 weeks. So we have better standardized data, more integrated data, and more timely data. But how do you use it for research? So at the end of the day, an EMR is a really good way to look up data. Back when I was running paper charts at UNC, 10% of the time, 1 out of 10 visits, which meant it happened about twice at a clinic, I'd be seeing a patient and not have a chart. So you'd walk in the patient's room and say, "Hi, tell me why you're here today." And that was the way it was. The patients expected it. I sort of expected it, and it was pretty crummy care, frankly. That does not happen anymore. So electronic health records are patient-centric, and they should be. Research, while we want to get information from patients, is about aggregating across subjects and research participants. And especially when we think about research management, we have clinical research or clinical trial management systems. EMRs are not magic clinical trials management systems for doing trials. You have to actually develop an interface between your management system and your electronic health record. And we spent much of the last year doing that at UNC. Duke is doing that as we speak. So there were these overlapping needs at the bottom, like basic study information, associating patient with studies, and order results. But there are some things that are really very specific for the research. But we can now, in the EMR, as a clinician, I can find out what studies my patient is on. I don't know which arm they're in, but that little pink bar says it's an active research project. I can click on that, and it'll say, Tim Carey is in project 01587. This is an oncology study. If you have a question, call this coordinator. So if the patient shows up in the emergency room and looks terrible, I can go, well, maybe it's the study drug, and I can call the study coordinator and figure out what's going on, maybe. So we have much more better reporting of who's on what study than we have ever had before. We do have an interface between our research management systems in oncology and non-oncology studies. Oncology has a lot of bells and whistles that are specific to that specialty. Now, a couple of years ago, there was an informatics person, when we were just developing the warehouse, who would get up and say, "This is the one source of truth for clinical data." I use that only in a negative way now. But where we want to go is to have reduced unit costs for patient recruitment. One of the most expensive things we do is pay research coordinators to hang out in waiting rooms, grabbing patients as they come by. That's a very expensive way to recruit patients in studies, and very inefficient because you're going to miss them. And reduce costs for data collection, because NIH is not going to spend thousands of dollars per patient recruited, nor should they. We need to have larger scale studies. The feds and the public are getting appropriately impatient of why it takes 7 years to get the results of a trial, when we could do it for some studies, not prostate cancer where the natural history is so long. But for other studies, if we had more sites, bigger sample size, we could have shorter time to get something that looked like an answer. EMRs have 3 basic roles in research. Recruitment for clinical and health services research work, finding the patients, whether we're talking to the patients or not, but finding out who has what. Tracking utilization, lab, radiology, and textual notes, which you can either analyze in your data warehouse or merge it with externally collected data, which could be an external registry, patient-reported outcomes, claims data if you can work out the governance. And third, use of the EMR as an intervention tool for care improvement. And the types of infrastructure and expertise you need for each of those roles are quite different. And it took me a while, because I'm slow in the uptake, to understand that those are really quite different uses and have different types of governance and expertise needed. So I'm finally going to get to the data warehouse, which is what you asked me to talk about. And these commercial systems, they produce canned reports really well. They will use something like tools like IBM Business Objects, and you get a dashboard. And when you talk to the vendors and you talk about research, they think of research as sort of a canned dashboard report. Because organizations, business organizations may describe that as research. Those of us in this room would not, because it doesn't have that iterative quality. What the data warehouse allows, and at UNC we're now in our 7th year, I think, of our large data warehouse, is it allows you to tailor your reports, to do more advanced analytics using your favorite analytics, SAS data, R+, whatever, C+, tools, as well as merge with non-EMR data, because there may be data you're collecting that's inappropriate for being in the electronic health record. And you can transfer partially de-identified data to other sites with IRB approval. And I'm going to leave governance not to sort of slides, but to talk about during discussion. Recognizing that a lot of this is messy data. A lot of these variables are still text. For example, if you're working in the heart failure arena, one of the key variables is how bad is the heart failure? How much squeeze does your left ventricle have? And it's a number like 15% if you're near death to 50% for those of us in the room. It's a text variable because the cardiologist wanted to be able to write in 35 to 42% maybe or something. So you wind up with text data, which you then have to put back into something that you could actually analyze with appropriate decision rules. Clinical notes are really hard to de-identify, and we've had to develop special ways of dealing with that. Because even if you take off the headers with the names and the address, people in their text will put, Tim Carey's mother-in-law was found on the Chicken Bridge down in Siler City the other night, and she was arrested, and he's really upset about this today. And you don't want that leaving your organization. I'm not making this up. The vendors will have these anonymized, very big warehouses that Epic and Cerner have, that as well as there are some other vendors that is fully de-identified. How useful that data is depends on how they do their de-identification protocols. And I'm sure your Stat Apps group has expertise in sort of how to statistically move the dates of care around. There are some problems that you can get into analytically doing that, as I understand it. So our own data warehouse is 6 years old. We've actually had enough experience that we have a feel for the pros and cons. We're moving to multi-hospital and multi-practice environment now. This has required really changing the structure of the warehouse. We can receive data from non-UNC healthcare system practices into our EMR if they're also on Epic. So I can look at Duke's records with a pretty modest permissioning process. That's a good thing. Looking at records from elsewhere, early signs are good that HIE may actually work in North Carolina. However, I recommend a detailed bill reading of the latest Senate bill in North Carolina that wants to sort of change the structure. Oh yeah, we can come back to that. Currently we have about 2 million records, and a record is a person. However, not all those people are alive. We have data going back, although the warehouse has been there for 6 years, the data goes back about 20 years. If you use a definition of seen twice in an ambulatory practice over the last 18 months or so, it's about 600,000 people. I think as we roll out to the other hospitals and practices in High Point, Pardee, Hallwell County, on and on, Nash, it'll be about 1 million people, I think. Duke's is a little bit bigger. Carolinas Medical Center is significantly bigger. We do have about 4 dedicated analysts, and we've done over 150 projects, many of those being cohort discovery. And we have done multi-site studies. So the governance, and early on we got actually good advice. We had a consultant come in to help us with governance. And it's probably the most important thing, I think, because the technical issues, they're doable. The governance is really a problem. We have an operations committee that processes the requests to make sure that it's actually the question is answerable with data warehouse data. We get a lot of naive requests. The analysts will do reviews preliminary to research just to make sure there are enough cases of X to make it worthwhile to do an extraction, or that the variables are not 90% missing. We also have an oversight committee that I have the pleasure of chairing that is joint between the School of Medicine and UNC healthcare system, because we realized that if you had one data warehouse for research and one data warehouse for operations, which one was going to get the resources? So we have one data warehouse, and that has worked. It's been an interesting process. We also have a consumer representative on the committee, and I may lobby for a second one. I think that was an important thing to do early on. So operationally, if you were going to try to get PCORI money, you have to have a consumer representative, but also she gave us excellent advice and gives us excellent advice on getting out ahead of the fact that we are aggregating patients' data and we are using it to try to improve their care. We need to say this in a proactive way and not responding to the latest Fox News breaking news. So we work with Duke on a couple of different projects that leads to some interesting governance processes of how do you identify who the 2 medical students are, what if hypertension control is better at Duke than at UNC or vice versa. We've worked some of those issues out. Worked with 6 other organizations doing data mapping on COPD, where we learned that pulmonary function tests, which are like 1.52 liters is the sort of number you get, are also stored as text in many electronic medical records. We do academic industry partnerships with SAS and IBM and others, including with NIEHS. But this is all still pretty early. I'm sorry this is small. It didn't project. So we've had over 150 studies, about 300 investigators. We do work with external entities. Every project has to have a UNC clinician linked with it, mostly to make sure that we're getting the data right, and it has to be a meaningful collaboration. Although we do move the data. If the data has personal identifiers on it, it has to stay within our firewall. And that's been sort of policy, and I think we're probably going to stick with that. However, we have developed a secure data warehouse, secure SRW, secure research space that has, you guys do this all the time, but it was new to us, that has data loss protections built in. It's really hard to download anything from it. Never say never impossible. You can always take screenshots with your cell phone, but we feel much more comfortable with this type of fairly radioactive data, where when you are linking external genomic data with EMR data, that there's no way to de-identify that data, even if you take the names off. It's because it's got somebody's genome on it. So the security issues can be a bit daunting sometimes. So we're moving to the system-wide issue. We've upgraded to an IBM commercial data model. We elected not to go with the Epic model, which I think was good because we would have, turns out, wasn't always clear from the commercials, that we would have been the beta site. So the new IBM model is working pretty well when we mapping the data from the old EMR data in the warehouse to the Epic data so that it looks reasonably seamless. There are some variable definition issues that requires lots of programmers to do data mapping. So far, so good. I think we'll be done with the mapping within a month or 2. So who's in there? If you look at, I think this is from the 600,000 seen in the past year or 2. Good age diversity, about 20% African American and 7.5% Latino. So it's reflective of the population of the state, which when applying for things like CMS data, when CMS interestingly wants to look at patient-reported outcomes, has been a good thing. So this is what you get. There's Pretty much everything's in there. When you talk with other organizations about what's in their data warehouse, and in the CTSA, I'm on external advisory committees with other CTSA organizations, and they say, we've got a data warehouse. You have to say, what's in it? And sometimes it's just claims data, which is okay, but it's not very comprehensive. And lots of issues about how is it coded? Is it textual data? Do you have something like natural language processing that you can analyze, which is hard to do? We do have NLP capabilities, and we're doing some early work in that area. It's not magic. So recruiting and tracking. The system can then daily scan for patients who meet criteria for the studies. And you can do this within the Epic environment, but the warehouse can do this as well. And then a provider or a research assistant is prompted to ask the patient regarding research participation. You have to be careful about how often you want to ask a provider to do anything with prompt fatigue. You do need a governance process, which we are putting in place to avoid conflicting prompts. The same patient might be prompted to get a PSA or not get a PSA, not at the same visit, bad idea. As well as how large is the population and how many prompts will that result in providers getting. Basically, when we turned the system on, we only had one prompt at the beginning, just because it was hard enough to get the providers to actually get through their visits. This generates regular reports on the number of patients recruited that you can get daily or weekly, and notification to treatment provider when a patient is in a study. So they look like this. Up top is a screening colonoscopy prompt that I get now, or best practice advisories or research recruitment. Patient meets screening criteria for an insomnia study. And then I ask the patient, are you interested? I've had you on Ambien for 7 years. I can say yes, and then I don't have to deal with it anymore. I click accept and it's gone. Now, again, we're going to be judicious in how many of these we turn on, but other organizations that have used this type of technology, whether it's an Epic or Cerner or the VA, have found it to be quite helpful, and it really increases your rate, and you don't have to pay the computer extra. Registries are a lot easier, and it's a lot easier with the new system than the old system. Getting people to give up control of the Excel database underneath their desk is going to be a challenge because there are big surprise control issues here. However, whenever we find out about one of these, we go through a vigorous counseling process that this is a really bad idea from a security perspective, and that they are responsible, and we won't be responsible as a university if they have a hack. And we just have to be clear about that. The cool stuff, getting to the cool stuff, is patient-reported outcomes. EMR systems now really do support patient-reported outcomes through their portal systems, so that a patient can, in a waiting room, in the office, or from home, fill out an SF whatever or a promise measure and have it loaded into their electronic medical record. They do support promise. Promise, as you know, is public domain. These are short. They won't allow, they don't support computerized adaptive testing yet, CAT, so you have to use the long form promise, which is still pretty short. Right now, though, only about 30% of patients actually use these portals on a regular basis. My guess is, you all as patients are probably all using it on an hourly basis, but it's about 30%. When I talk to folks at the Mayo Clinic, which is probably as medically sophisticated an environment in Rochester, Minnesota, as exists, they say 30–40%. But that's only going to go up over time as the non-users die off, literally and figuratively. A key issue that I'm spending a lot of time talking to investigators at UNC about is it's like Las Vegas. If the data goes into the EMR, the data stays in the EMR. It can't sort of pass through and then exit without being accessible by doctors, nurses. And this is a legal requirement of medical records, just as you wouldn't want your doctor to be doing their charting in pencil so they can erase something. That would be the equivalent, and there's just no way to change that. So if a response goes into the EMR, it's going to be visible. So you may want to collect data outside of the EMR and then link it within a data warehouse environment, which is why you have to have a data warehouse, at least in the current environment. how we're going to handle Fitbit. Y'all familiar with Fitbit? How many of you have a Fitbit? All right, only one. I bet others of you don't want to raise your hand. Is you can upload these, and the EMRs, as marketing more than anything else, will accept Fitbit information, home blood glucoses, et cetera, which is great, but as a provider, what the heck are they supposed to do with this information? Patients would be doing peak flows 4 times a day from their pulmonary function test, uploading it, and then the providers were unclear how to visualize that data. And I think this is a real need for research moving forward. And there's some folks in School of Information and Library Science and at RENCI, and I know you've got folks at RTI. And speaking as a clinician, I need help in that area. So this is what the promise measures look like, and it's really pretty cool. How would you say your health is? Excellent, very good, fair, poor, et cetera. Promise has, I don't know how many measures. How many promise measures are there? 17 or something. Yeah, there's a lot of them. Right. And loading it into or doing the programming within the EMR takes like a day or two. It's very easy to do. However, developing a workflow of when the patient fills it out so the nurses actually do it, that's a lot more complicated. And we're doing this now in like 3 clinics, I think, with Go Live, and we're learning more about that. Initially, I've been summoned to the Carolina Population Center, I think this week or next week, to give this talk, and they've got big surveys they want to upload, and I'm having to do some counseling with them. They're wonderful people, like my colleagues at the Pop Center. Intervention, this is the final frontier. We know that sending doctors prompts and reminders, or nurses or dentists or whoever, it only gets you so far. These are modestly effective. One of the first studies I did at UNC was we were putting sticky tabs on paper charts to get people to give flu shots and colonoscopies, and you get about 10% on your flu shot rate when you do that. If it's a EMR prompt and a reminder, you might get 15%. It's not magic. But within these EMRs, there's now a lot of behavioral interventions. This is like the nudge of behavioral economics. So there are people doing sort of shaming behavior on the EMR, where the prompt will talk about how other people in your clinic are doing so much better than you are. And, guilt tripping me and then putting my name against everybody else's. But the docs will get prompt fatigue, because one of the things you notice when you go to these systems is your time burden increases, and there are real concerns that the providers are spending a lot of time staring at cathode ray tubes and not looking at the patient. I've had 3 patients so far tell me that, and I try to do the right ergonomics and sort of move the screen so they can see it, and I'm doing this. They say, why are you looking at that screen so much while you're clicking? We're working it out. You can incorporate recommended treatment plans and order sets within these prompts. So you can, it'll automatically, more or less, schedule the colonoscopy, so it can be a reduced number of clicks. But there are these governance issues of, if you do a quality improvement intervention, when does it become a study, and who do you have to consent if you're turning a system on to everybody at UNC hospitals and Rex is the control hospital? Interesting IRB issues. Guidance from various federal committees up to the secretary is that probably does not require individual consent, but you may want to let people know in more general ways what types of projects you're doing. But there's a lot of heterogeneity from IRB to IRB around the United States on these issues. And as we move to things like large pragmatic clinical trials, we're going to have to deal with this. And I don't think we're talking about it enough. And as I said, I think we need to get out in front with the public and talk about that we're trying to make the healthcare system better when we do this. Now, you wouldn't do a study of, we're going to give you the blue pill, but we're not going to tell you what it is. And it's not FDA approved, of course. That requires individual patient consent. But if it's within, we're going to use colonoscopy order set A versus colonoscopy order set B, and determine who gets more colonoscopies, because we don't really know how to get people to get their colonoscopies every 10 years. That, I think, may be defensible, as we're not going to individually consent to patients. We're just going to inform them in your quarterly newsletter or whatever that we send out to patients. So there's some interesting governance issues with this, and it requires talking to the IRB well ahead of the submission of the project to both get a temperature reading, and they'll never tell you exactly what they'll approve, nor should they, but to get a sense of sort of where the field is heading. And they know this is coming, and they're actively talking about this. And in calendar 2015, we should be doing this, I think, at UNC and Duke, because we're actually putting in joint projects. So the plan here is to go to scale, not just in terms of data mining these large warehouses, but in terms of doing large cohort studies, registry studies, and intervention studies. NIH has an initiative they call the Collaboratory, which is a terrible phrase, but that's what they call it, which are large integrated delivery system-based trials of things like taking some of your antihypertensives at night instead of the morning. Very simple. And they're not even randomizing that. They're randomizing advice to take one of your blood pressure medicines at night. You find people on more than one type of medication, and basically they get a prompt saying, we think you should consider advising your patient to take their enalapril at night instead of the morning. Very simple study. A colleague of mine out at University of Washington is doing a study randomizing radiology departments for patients that have degenerative changes, which are basically wear and tear changes of the lumbar spine, epidemiologically informed text into the radiology report that will discuss what we used to call degenerative changes of the lumbar spine as normal aging. So the only intervention is the text in the radiologist report. Pretty cool. And we can do this with these types of tools. Carey, Patient-Centered Outcome Research Institute, developed by the Affordable Care Act, very complicated and sort of wild and woolly times working with them. They have bet a lot on this technology and are spending between $70 and $100 million, real money, on developing networks and harmonized networks of electronic health records and warehouses, so that across different EMR systems, across Epic and Cerner or whatever, we can recruit patients into trials as well as look at secondary data. And it's called PCORNet. Duke and HMO Research Network are the coordinators. They're herding cats as fast as they can. This is interesting interface between clinicians that want to do care better and what I call big I informatics people who use a very different language from that of clinical and health services researchers. So in the field now are 18-month grants, very short time, trying to get the data harmonized and come up with some methods that then will become national standards of what they call the clinical data research networks, or the patient-powered research networks, which are basically grants to advocacy groups to link their social media tweets with EMR data, which, just imagine the governance issues going on there. At UNC, a talented young investigator named Mike Kappelman is working with the Crohn's and Colitis Foundation in a remarkable study where it turns out talented young kids with Crohn's disease will upload their dietary preferences into a database and then correlate it with their Crohn's activity, and linking that to their pathology reports or inflammatory measures could be quite powerful. Sounds good in theory, but can we actually work this out? The Clinical Translational Science Award needs to link with these networks because we need one system. Otherwise, we're going to wind up with the equivalent of, I use ICD-9 and you're using something else. So we do hope to be able to go to scale. This is a multi-year project, and hopefully within the next 5 years, we can be up and going on this. This requires us as health services researchers to get out of the comfort zone. This is really different from claims analyses. When I talk to people who are used to claims analyses about this type of work, they say it's messy, it's got lots of missing data, yet claims data are derived from this data. It's just that you don't see the messiness in the claims data because it all gets sort of smoothed out by various coders and harmonizers along the way. But for some analyses, it may be more useful. I think we're still going to need claims data, especially if we can link the claims with the EMR data. That gets really complicated. Even in these integrated delivery systems, people who are mostly seen at UNC may be seen at Duke, may be seen at Triangle Orthopedics, wherever. Claims data can help you to identify that care that occurs out of network. And accountable care organizations are grappling with this right now. When I go to Blue Cross, and I have, and said, gee, why don't you just let us link all this data, they get very nervous because they worry that that might give UNC a competitive advantage. So we're going to have to develop ways to keep the commercial part, the care part of the system, away from the research part. But eventually we're going to need, for research, they don't want UNC healthcare system to use Blue Cross claims data to develop a competitive advantage over Carolinas Medical Center or whatever. Because if you have claims paid, you could figure out what the contracting was. I'm sure people in this room could do that like in a heartbeat. But some claims data, I think eventually we're going to have to cut that deal. Certain states have done this. North Carolina has been, frankly, fairly slow. You need local knowledge of what's going on within your own healthcare system to be able to utilize this data. While there are, for some diagnoses, like diabetes, really standard ways of defining what a diabetic is, either 2 ambulatory visits or 1 inpatient diagnosis for diabetes, or these 17 drugs that you may be on that are only used for diabetes, or a glycosylated hemoglobin greater than whatever. You can define that standard around the US, but for many other diagnoses, we have not developed those yet. So you need somebody that really knows the data, like the data warehouse programmers that we have, who understand, well, for this diagnosis, the problem list may be better than your billing diagnosis. For that diagnosis, you really need to drill down within the legacy systems, et cetera. This is not easy. So locally, we do have an informatics core at TRACS at the UNC CTSA. It is easy and fun to join the CTSA. I think you just kind of put in your name, I think. Click yes, and then we can say you're a member. If you're thinking of doing a study, it's basically a little blob of text that you have to put in. And then you meet with an analyst, and they give you pretty good advice, usually. We currently have 2, for intervention studies, 2 programmers who are EPIC certified. That has to occur within the firewall. You can't write a little EPIC text in your spare time and we're just going to put it in. It's got to occur within the firewall for obvious reasons. We also have analysts who work with the warehouse data, and we probably need to double those numbers. We do provide consults through TRACS, and we do have pilots, and I think there have been a couple that have come from RTI, some of which have been funded. And y'all have the slides, additional resources that I use. The PCORI is developing methods materials, and they have a bunch of webinars that are open. Same for the collaboratory. The ARC supports the electronic data, is it CM methods, I think? The EDM forum that I have found to be really good. They have good materials there. They have some special issues that they've used. I think Academy Health is the contractor. And Amy, if you want to get into the academic part. That's it. So questions, we have about 15 minutes. Yes, sir.
So we have quite a few online questions, and I think what I'll do is I'll put them on your screen.
Oh, okay.
And let you. Can you see them now?
Nope. Or I can repeat it. Nope.
Some operations going on at Duke about 7 or 8 years ago in their immunological research labs. And one of the things that was of interest is that every lab had their own access database for their limbs. This is really a governance question, and that still exists.
So the question is, Within research databases for biological specimens, that is a total mess, and it is always a governance issue. There are thousands of, I call them the freezer people. There are freezers all over campus, and researchers put their specimens in them, cool them down to liquid nitrogen temperatures, and they view them in a very proprietary way, that is their property. Well, it's really not their property. It belongs to the university. Having a standard coding system across this was supposed to solve all the problems. It's been very complicated. At UNC, I think we're doing a good job with oncology specimens. We have a good tissue procurement system, but we don't have a university-wide LIMS or other system for that. So it's in the data warehouses, not the tissue or specimens collected solely for research. It's the clinical work, it's the clinical activity that's in the data warehouse. Even more complicated is genetic information, which is now very common, very varied, and very big. We're doing GWAS on patients now. And where does that data sit, and who has control over that? And we have a major initiative pending before the Vice Chancellor that I just saw a draft of, where they're going to try to sort that out. But I think the problems aren't technical, the problems are those of governance. Yep, right, if they're using different coding systems. So the first question here is, how do you access it and how much does it cost? Access it through the TRACS portal. Now that's, in terms of access, that's access to talk to the TRACS folks. In terms of being able to touch the data, you have to go through a process which includes IRB and feasibility. I'm hopeful within the next year we will have an I2B2. Do you know what that? I2B2 is an anonymized, oh, there it is. I2B2 is an anonymized method of doing cohort discovery on totally de-identified data, so you don't have the text, no dates of service, et cetera there. But it allows you to text laboratory value, to search laboratory values, diagnoses, et cetera. It was developed at Harvard, and it's got the phrase biologic and bedside in it. I forget what it stands for. That can be somewhat self-service, but to do the extraction, you have to go through the programmers, because I think unless you really know the data, you've got to go through the programmers because they really know the data. In terms of cost, we have a standard programming cost. The first day or two is free because TRACS subsidizes this service. Similarly to our secondary data of internal folks working with MarketScan. So 80% of our downloads, where somebody just needs a database or a list of patients, we can do at zero cost to the investigator. However, if you're going to be doing a smart set and ongoing testing within the EPIC system, that's probably going to take at least a week of programming, and there'll be an hourly charge for that chargeback. Yeah, Lisa can help with that. If you just go, who are these people and all that, sure. Linking with the UNC investigator, and again, is a good start, who has content expertise in that area. They may be a good clinician, they don't have to be an NIH investigator. Question from Sue West. Hi, Sue. So were we able to upload all of the patient information from WebSys? Yes. So WebSys was the old system. Sue West was a veteran. She was like the only person ever to actually get under the hood there and grapple with it. And it took us a long time to get that published. So we have mapped the data from the old EMR system to the new EMR system, and the programmers will know there are some variables in the, almost everything in the old EMR system maps to the new EMR system. There are variables in the new EMR system that were not present in the old system. Does that make sense? Kind of like ICD-9 and 10, right? You can always map 10 back to 9, but you can't map 9 up to 10. I learned that from somebody in this room. Regarding data sharing, are there limitations to anything you can share? Substance abuse, mental health, behavioral health data, or other sensitive information. How sensitive is sensitive enough is something we've been working through. Now, with an appropriate IRB, that can all be done. Now, the more sensitive the data, the less likely it can move external to UNC healthcare system servers. We do have mechanisms for outside investigators to VPN in. They have to go through, unfortunately, another set of confidentiality training in UNC systems and all that. They're just going to have to do that because they're accessing a UNC server. That makes sense. It's painful, but for very sensitive data, especially if it's identified data. So in terms of linking, there's probabilistic linking and deterministic linking. We have done linking with this of both types. This is fully identified data in the warehouse. Now, we will only allow individuals to work with identified data if they have a reason to work with the identified data. If a probabilistic link will serve your purposes and you have enough other identifiers that you think you can get up to a reasonably valid linkage, then you'll be working with the limited data set and not fully identified data. I'm hopeful to get the database geocoded in the next year. It's been something I've been working on for a while, and it's basically resources and priorities. I'm unable to do it right now because we're still busy stabilizing EPIC. Does UNC use I2B2? We will be. We have the instance now, and we have a programmer who's an I2B2 programmer. That the informatics folks I talk with aren't crazy about it, but it's kind of the lowest common denominator that everybody uses. And we're going to be stuck with I2B2 for a while. It's basically Boolean logic. It's not, when you look at it, you go, this is not rocket science, and it's not, but it's become what everybody feels comfortable with. Can patients opt out? Yes. There is a security system within EPIC. There's also an opt-out in health information exchange in the state. Believe it or not, North Carolina does have health information exchange legislation. And the default is information will be exchanged with your provider, around all things. And I believe mental health is not opted out because there was a lot of discussion that we do a lot more harm by not knowing the psychiatrist that the medications the psychiatrist gave to my diabetic patient that's making their diabetes worse than me being unable to understand that me doing something with that data that's inappropriate. Patients can opt out. There's a little lock security on it. As a clinician, I can what's called break the glass and get in if I have a clinical reason to do so. I just have to document what that reason is, and if I start doing it a lot, somebody's going to come knocking on my door. It has pretty good security systems. We had pretty good security systems with the old WebSys. I actually had to call somebody to get into the lock charts. So patients, my understanding is patients do have an opt-out as well. Now, whether we're going to use the opt-out for other clinicians looking at my data as an opt-out for all research invitations, that's actually not clear. And there is a committee now looking at what that general consent is. When you go see a provider at any major medical center, you sign a general consent for care. It's written in about 4-point font. It's, I think, both illegible to anybody who's not 2015 eyesight and also written by lawyers. My IRB colleagues tell me what you put on that has no meaning at all for IRB, either in a positive or a negative way, because it's not informed for any particular study. However, looking at charts and utilizing data without intervention is generally considered exempt from consent and often considered not human subjects research. And the move right now is to have more oversight for higher risk studies and actually less oversight for the kind of work that we do collectively. And there is now a guidance sitting on the secretary's desk, except we now have a new secretary, of DHHS at the national level, which would move a lot of quality improvement work and say, really you just need to register it with the IRB as opposed to saying that the patient has to sign consent so you can abstract their chart. Now, do patients understand what we're doing with their information? Often, I think not. Do patients understand or people understand what happens when they use their VIC card? Right? Okay. Harris Teeter sells this. We don't sell the data. We do use it for research. And that's on that 4-point font document that patients sign at UNC and Duke. How often do people actually read that? I think probably not. And that's an area I think we have to do a lot better job with. Let's see. Is there greater hazard from data errors since the same data influences more aspects of health management, since there is no redundancy of data entry? Yes. There's a whole field out there now of errors induced by electronic health records. Including, I found the workaround literature the other day. There's a whole literature on how providers will try to subvert the EMR. If the EMR is making them go through a process that just doesn't make any sense or drives them crazy. A big intervention the last couple of years has been barcoding the patients and barcoding the pills. So every pill, these are single dose, has a barcode on it. So you swipe the pill, then you swipe the patient. Perfect. How could this, what could go wrong? Well, turns out that in some systems, you know, if it gets smeared with a bodily fluid, it may not be there, and, you know, it can go wrong, it turns out. And these are not error-free systems. What in my read of the literature is, in general, errors go down with electronic health records. Other types of errors go up. So there are errors that are induced. In aggregate, I think it's still a net win. Certainly in things like ambulatory care, relatively minor errors tend to occur quite a bit, such as none of these systems print very well. You'd think they would have figured it out, but they don't print well. So giving the wrong prescription to the right patient can occur. Yeah. Any questions here? Kathy in the back, who needs no microphone.
This is not so much a question as a PS or a footnote to your comments about quality improvement and other kinds of studies like that that might fall into the cluster randomized trial sort of formulation or structure. The Canadians and the Brits and some international people a couple of years ago developed very detailed bioethical principles for informed consent for cluster randomized trials, starting out with who is a subject and who needs to be informed and so forth. So if you or anybody's interested, I'm happy to pass along the citations.
Thank you, Kathy. Yeah, we are going to need that. These, you know, things like stepped wedge designs and all that. It's pretty cool. But absolutely, we need to have ongoing dialogues with our regulatory folks. Thank you.
Georgi Barbashov, I'm a statistician and modeler, do some predictive modeling. So my question is, how do we get connected with UNC scientists? Because we've been developing a number of really interesting methods on personalized treatment and choosing between the best treatments and whatnot. And actually, a number of things that you presented today, I was just saying, oh, okay, just making a number of notes, saying, okay, we've done that, or at least we can help in this area or in this area. But now the question is, what will be the next step? Should I contact you or somebody else, or just how we start that collaboration, especially given the fact that my grant funding has ended. We developed this methods. The methods are here. So if we either just start thinking of new grants or there is some funding already.
Well, certainly we have a joint, the next RFA is in July. We have a joint pilot program. You don't have to have a pilot to get it done. But if you're going to be using more than small amounts of programming staff, you're going to have a pilot. Best way is to go through Lisa Getland, Don Bailey, or myself. In more biomedical areas, such as the metabolomics folks and all, we have other initiatives around those areas. This is not just about health services research. In terms of predictive modeling, there's a lot of folks interested in predictive analytics, which sounds great, and it sounds space age. I find sometimes I think we need more basic analytics and actually use them if we're going to make care better. That's my personal view. Especially as we look at biopsychosocial models, because I think The big bugaboo right now is patients who are repeatedly hospitalized. And often it's not the physiology that's leading to the hospitalization. It's often social contextual factors. That's just me. Last question. I want to thank you all. This was fun. We'll do it again. And thanks to Waltham.